Yeah, thanks very much. You know when you volunteer to do something and then later on you look at all these people in the audience there, that really wasn't a very good idea. So bear with us. So we're going to talk about parity of esteem in the context of factitious and self-injurious behaviour. So Kath ran over a little bit, so I feel a bit reassured that I might as well. Okay. So one of the things that's really important, self-injurious behaviour is really has a resonance for lots of people, whether it's something that you do yourself or something that you are aware of in a family member or you know something that you've actually encountered. So number one really for the start of the presentation is make sure you're safe to stay in for the topic that we're going to discuss. It's very emotive and it's very raw, and we are going to talk about specific injuries. So if you feel comfortable, then that's fine. If you don't, you should excuse yourself from the session now. Okay. So we're going to say that tissue viability is more than just providing dressing advice. I'm not going to talk about the wounds and the wound management as such. See that the patient is complex and not their wounds. And as we've said before, in lots of the injuries that we see, they're actually a consequence of a systemic or psychological problem with the individual. And so I see wounds more as a symptom rather than as an external manifestation of something else that's going on. And parity of esteem plays a part in wound care in a complex non-acute care setting. So I work in mental health and LD, and so we have to manage wounds in a very innovative way often because our clients won't concord with the treatment plans that we put in place. And we're going to show the benefits and pitfalls and the requirements of collaborative working. Now, I would ask you that you bear with us because some of the slides and some of the quotes will get people's hackles up. They may upset you a little bit, but when you see hopefully the end slide, you'll understand how we bring that all together. And learn from some of the lessons that we've learned in the process of actually going through this. So just as a bit of clarity, a factitious disorder, people are very familiar with things like Munchausen by proxy, and I think people are very comfortable with that. They hear it a lot. But factitious wounds is a bit more complex because we're talking about situations where patients will perpetuate an injury way beyond its normal healing expectation. So we're seeing injuries, we've seen a hysterectomy scar that was 25 years old that was being maintained by a patient. And obviously there's underlying reasons for that. And usually it's there are sometimes physiological causes for that, but invariably it's a psychological process that leads to that. And parity of esteem, I think most people are familiar with parity, and in the context of parity of esteem in wound care, what we're basically looking at is that as an individual, regardless of your background, your colour, your creed, your religious choices, or your mental health or learning disability, you should be able to access the same level of care as if somebody who would be classed as normal would front up and turn up at A&E or at a specialist department. And clearly the case example that I'm going to give you, which on the face of it is quite complex, you'll see how everybody has a part to play in that. And from all of our point of view, all of us want to be held in some level of esteem, don't we? We want to be valued and respected for who we are, what we are, and the various things that have contributed to who we are as individuals in our lifelong learning and development. So the mental health, no health without mental health, identified in 2011. First time really in documentation where we talked about parity of esteem from a mental health point of view. And I think in the context of what we're talking about, we want equal access to the most effective and safest care and treatment. I think we all want that regardless of what your background is. Equal efforts to improve your quality of care, and this is about how you're viewed and respected and held in esteem by somebody. So if somebody doesn't value who you are, it's unlikely that they're going to give you the best choice and the best access to resources and equipment. The allocation of time, effort and resources. When you see some of the quotes that were presented to this individual that I'm going to talk about, you'll see where that plays a part. And equal status within the health, education and practice. TVS for a number of years now have put mental health on the agenda. It's something that historically wasn't out there at all, and most of you will be aware of that. And when we talk to colleagues in acute setting, they say, well, we need more of this. We don't get it. We don't work in mental health. I've been an RMN for 37 years. And in that time, often we'll hear, well, mental health, that's not our bag, so you get on with it. Well, it's everybody's bag, isn't it? We all should be seeing the patient in the process of their lifelong journey. And we should, as a service, be providing that intervention based on what the patient needs at the time and not deciding whether or not I'm an acute nurse or I'm a mental health nurse. And equality of equally high aspirations for the service user. So lots of our patients will say, well, I don't want to go to the acute trust, because when I go to the acute trust, all they do is judge me. They don't know me, but they make a judgment on the fact that I self-harm. And therefore, I don't want to go, because at least here, I know you know what I do and why I do it and what are the antecedents to that. And equal status in the measurement of health outcomes. So you and I, if you front up with an injury, you expect that the intervention that you'll be provided with will actually treat that injury, hopefully to heal. But actually that level of expectation with some of our client group isn't actually number 1 on the list. It might actually be number 10 on the list. Getting them in, getting them out, and not having any bother in the reception might be number 1 on the list. Okay. So there's a lot of terminology that goes with self-harm. Some of them you'll be very familiar with. I'll not spend any time on that. And really importantly, everybody self-harms to an extent. Whether you overeat, whether you like a drink, whether you like a smoke, that's all classed as self-harm. We all know that it does negative things to our body. And in the context of things, it's a continuum, isn't it? From very mild self-harm, like a nice gin and tonic, to some of this self-injurious behaviour where people are inserting branches of trees into their body, or staples, or metalwork, or whatever it happens to be. And I quite like this quote: self-injury is like normal self-injury, but just out of control. And when you talk to people who self-injury, actually the out of control bit doesn't always come into the equation. For most self-harmers, control is actually one of the number 1 criteria. That actually the control is something they lack in other aspects of their life, and therefore having that level of control is something that actually eases the process of the self-injurious behaviour. So I like this one from Sutton. There's a couple of books at the end I'll show you, but the Jan Sutton book is fantastic if anybody has an interest in reading it. Self-injury is an expression of acute psychological distress, is an act done to oneself, by oneself, with the intention of helping oneself rather than killing oneself. And often people think that self-injurious behaviour, the outcome is to die. If you ask anybody who self-harms, actually usually that's not the primary thing, because they don't self-harm, they commit suicide. Self-injurious behaviour is more about survival, a medal of survival rather than a medal of self-destruction. Okay. So, if you feel comfortable, I'd like you to just think back. The case that I'm going to talk about is a 16-year-old. So if you can think back to when you were 16 and all those emotional, psychological, peer pressures, hormonal impacts that you had in your life, and how you had to internalize and socially manage those, and then try and think from that perspective for this individual, rather than as you are now as professionals and as individuals who've got lifelong learning. So, self-harm can also elicit lots of positive and negative feelings from individuals. And some of the ones that we're going to talk about in this case study tend to be perceived as very negative. Shock, anger, revulsion, fear, panic, and sadness. We all, I think, would like people to be able to understand the two aspects of that. So understand the negative, but also promote the positive side of it. So here we go. We have a 16-year-old female who is on one of our acute children's unit beds. It's a very specialist unit that takes the very damaged children from right across the country. These children have a lot of underlying problems. They were admitted to the secure adolescent unit after a failed care package in their own locality in September 2018. They were admitted under the Mental Health Act for treatment under the Mental Health Act, but importantly they were known as Gillick competent. And Gillick competent basically means that they have enough maturity to understand the various needs in, as far as decision making within their lives. And the Gillick actual case was around contraception. where a daughter wanted to have contraception. She was 14 at the time. Mum took her to court and said, you're not able to do that. And she won the case basically because she was mature enough to understand its impact on her body, and her choices moving forward. So this individual is Gillick competent. She has a long history of repeated self-harming from the age of 11, and a long self-harm initially was reported as very covert, which again is very common. Lots of self-harmers are very covert initially in their self-harm and their management, basically because they don't want anybody to know, and it's about control that they have. There was a long-standing multiple episodes of physical, psychological and sexual abuse by a close relative, and I haven't put it on here, but there was a pursuant abuser as well, which is one of the difficulties in moving the patient out of area. And following feelings of low self-worth, self-loathing, depression, suicidality, multiple suicide attempts, and an estranged family. So you can already see a really complex case for this individual. Her feelings were around, I'm worthless, I don't deserve anything, I'm not good enough, I was a mistake, I shouldn't be here, I'm bad and I'm evil. Now they're all very negative, aren't they? She had negative core beliefs which were all around about being incompetent, inadequate, not able to take control, I'm defective. If I wasn't defective, these things wouldn't happen to us. Again, very emotional stuff. All of those things really led to low self-esteem, self-hate and self-loathing, all potentially exacerbating the self-injurious behaviour. Underlying all of that, unfortunately, she had lots of verbal aggression, which was directed at staff, her peer, patients, and family members. Physical aggression directed again at staff and environment, and targeting fixtures, as you can imagine. We all do that, don't we? What's the saying? Kick the cat. No, don't. That would be bad. Verbal outbursts with inappropriate content, and antecedent to self-harm behaviour. So she would often verbally escalate her behaviour just before she then went away to find some way to self-harm. Again, about gaining control. And the self-injurious behaviour was sometimes spontaneous. Fluctuating engagement and attachment issues. So that's really important, as Kath was saying about that, building a rapport with your patient, being able to get with them and understand what they need, when they need it, and how they need it. And if you can tune into that individual, then they're much more likely to be concordant with the treatment plan that you want to come up with. And as a TVN, that's one of the main things that I would have to do with my colleague Heather, is that we would actually say to the patient, well, what do you want? What do you need to happen? How do you want to gain control? Because ultimately, if you try to control self-injurious behaviour, you normally make it covert again, because people will continue to do what works for them, but in a covert way. And she did stockpile equipment and take advantage of things that are around, but we're in a secure unit, and that secure unit has got lots of those things removed. So again, we're narrowing our choice, which is quite difficult. This is a selection of some of the things that she's actually, on one occasion, we took out of her. So there was actually 3 pen inserts under the skin, bits of wood, staples, a straightened out large paper clip, and there's a needle in there. But we've had lollipop sticks, glass, crayons, all sorts of different things inserted inside the body. So the client, she inflicted a self-injury to her forearm, which was a very large incision with multiple smaller incisions further up the arm. Immediate first aid was provided, as you can imagine. Client was offered specialist review at our specialist burns and plastics department, and they were familiar with this individual. Initially, the client refused, and this was all associated with feelings of self-worth. Well, I don't need to go. Why do I need to go? I'm not worthy. If I die, then nobody will have to worry about me anymore. It's hard to understand, so if you can think about that question there, about how to understand those feelings of emotions that that person would go through, it's very difficult. You then add in the crisis of the self-injurious behaviour, and then add in strangers, unknown departments, even though she'd been several times, but people within the department would be often unknown to her. There was other impacts on that whole scenario, and that was about attitudes of our family. Our parents at one point had said, well, we don't want her anywhere near our siblings because they might mirror her behaviours. So if you're that individual, how does that make you feel? Even less worthy, even less finding your place in the world. So this is the wound, one of them. As you can see, it's not, in our world, it's not a significant wound, but when these are multiples and happen on a frequent basis, they are very difficult. So, as a team, we worked diligently with this individual. She didn't want to go to the A&E department. She didn't want to go to the plastics department. She certainly didn't want anybody interfering with it. Having the philosophy, well, if I've got all these things in, I get an infection, and then I die, then the world will be a better place without us. So the team on the ward are dealing with all the sort of cognitive behavioural therapy side of it, thinking in different ways, doing the DBT as well, getting this patient to do some group work and looking at how she could find worth in the world and have some kind of future that she might be able to not only anticipate but work towards. Excuse me. So after doing all of that work, we then spent probably 2 weeks after the initial injury, which luckily hadn't infected at that time, but still had other items inserted in the interim. We then persuaded her, it's a bad term, isn't it? We then engaged with her really to see our wounds in a different way, to be much more positive and proactive. So she was then much more positive about how she would proceed. So once she saw that she had worth to ourselves and others, she then decided that she would be concordant with us referring her to the specialist team. So we then re-referred to the department, said, right, this individual is now in a position where she's willing to undertake the treatment. Is that fine with you? Agreed an appointment. We also agreed that we would make specialist adjustments for her. So the team made sure that she had a low stimulus room, that she was able to not sit in the main outpatient department, that she would be sequestered somewhere where she would feel safe with our team members and comfortable and quiet, which again is good. Okay, unfortunately, as she walked in the door, and these are direct quotes, I'm afraid to say, so the specialist team, including the medics and the nurses, basically said, oh no, not you again. Haven't you learnt your lesson? What's the point? You'll only just do this again. Do you know how much time and effort was spent in cleaning your previous wounds just for you to do it again? And come on, let's get this done so I can get on to my real patients. So you've got, I'm glad that shocked, it was like a Mexican wave went through the audience there. I mean, those are all things, when you bear in mind that the professionals in the department that received her knew nothing about our antecedent behaviour, any of our history, any of the things that had contributed to that behaviour, anything about her as a person. She was literally a body walked in the door, although they had seen her as a department previously. But ultimately, they didn't know about that. To the staff who were accompanying her, can't you lot manage this? Why do you let her do it? We should safeguard this. You clearly fail her. Can't you stop her getting things? You should take everything off her. And why can't you just restrain her? And at one point, somebody actually said, well, why don't you just put her in a padded room and with nothing in there, and then she won't self-harm at all? Okay, very sad to hear that, isn't it? Okay, so then the individual was dealt with, and I've put that in inverted brackets because that's how it was. There was no interaction with the individual. There was no understanding of the feelings, emotions, and pain this individual was going through. It was very, very perfunctory, the actual interaction with her. And the staff challenged this, and they were told, well, if we encourage her, if we ask her anything, it'll just perpetuate the behaviours. And also this really horrible saying, attention-seeking. It'll just feed into our attention-seeking behaviour. So she was given a local, the wound was open, and the items fished out. And again, I put that in inverted commas because, again, there was no delicacy in let's have a look and if we can do this in a way that because bear in mind she's sitting watching this happening. So then we go. All of that was done. The client's in the car on the way back to our specialist unit, which is about 15 miles away. And then in the middle of it, she rips the dressing off, tears open the wound, screams she wants to die, and the team members have to do an emergency stop in the middle of the road and then do a physical restraint to stop her actually interfering with the wound. You can imagine the emotions for everybody involved in this. So we get her back to the unit. Well, the royal we, get her back to the unit. We ring up and say to the team, oh, this individual has reopened the wound. Can we organise something to have the wound properly reviewed again And then you can clearly see what the statement was. It basically validated this. See, you can't manage her, you're useless, we'll safeguard this, and she's just attention seeking. Now, can you imagine why she did that? Clearly because what the team had done was validate the very thing that she thought about herself in the first place, that she's not worthy, she has no place in the world, and the world will be better without her. So for her to then revalidate that, or them to revalidate that, she literally went, well, clearly this is how it is, so I might as well just do something about it. I think that's part of the difficulty. One of the things I would like to also demyth is this thing about attention-seeking behaviour. It's a horrible term anyway, but most people who self-harm, if you talk to them, or indeed if you do it yourself, it's nearly always covert. And the reason that it's overt on our unit is because there's no privacy. They're on a unit that's a specialist forensic unit where the staffing ratios are high and where there's somebody about all the time. So it's very difficult to get access to something that had been a traditional behaviour for that individual. So effectively, we've removed some of that coping strategy. Okay. I quite like the idea of help-seeking rather than attention-seeking, personally. So, this is really important. This is not about me and as a mental health nurse saying to the team, by the way, you're rubbish. Because it's not. We work in a whole system and we should work as part of that whole system. So we have a duty from our point of view to share that information. If we don't say to the receiving unit, by the way, this individual has really poor self-esteem, self-loathing, suicidal ideation, sees themselves as having no value, what we'd like you to do is just engage them in a very human way, but don't reinforce the behaviour. You don't have to validate the behaviour to work with that individual as a person, do you? Okay, we should negotiate with the client what their needs are. Again, like Kath was saying with her bariatric patients, or severely obese, sorry. Yes, okay. So what does the client need? What does she want? What does she need from them? Does she need them to give her a hug? She's 16. She's going through all those emotions that we talked about before. She might need us to be much more parental and nurturing because it's something that she's not got in her own life. And that's not wrong if it gives you the right outcome for the patient. You'll all have your own views on that, but that's my view. And given the frequency of the reviews and the number of events that we had, we need to develop a RAG-rated response plan. So what do we do when everything's fine? Well, we might allow a certain amount of self-harm, but we'll manage it in a very local way. If it's escalated, it might be an amber rating, and what do we do as an intervention? And what do we do if it becomes a RAG-rated, a red-rated response? How do we interact for that individual? Is it a 999? Is it a preemptive call to the team? Is it a negotiated slot? Whatever that is. And the specialist teams discuss with them what can and can't be said and what the rationale for that is. You know, if somebody turned up and they were a different colour, somebody wouldn't be racist in their comments because they understand the impact on that individual. So why have they got a different attitude and a different belief system that they could do that about somebody's physical presentation and the motivations behind that? Promote non-judgment attitudes and talk about this parity of esteem and reinforce empathy. Isn't it sad as nurses we have to reinforce empathy? I would say that's my raison d'etre as being a nurse, is that empathy is part of my core beliefs. I would hope, anyway. So we are developing a robust joined-up care pathway for the future, and we're involving the young people in discussing and identifying what that would look like for them. We've developed a responsibility checklist. So when somebody goes in, what do they do? Who does what? Is it us that does some of it? Is it the receiving team? Do we take control? Do we not take control? Do we give it back to the individual? We negotiate that ahead of time. And we've invited the team to come and do a tour of our specialist unit so they get a proper idea of what we're like, that we don't have all these little padded cells and restraint belts and straitjackets in the corner, that we actually, people have individual time out, people have ground leave, people have rights to be able to go to the cinema, but it doesn't mean that they're not having treatment for their mental health problems. And this has been trialled in other areas of the trust. And if anybody heard my presentation last year about my gentleman in the secure forensic unit for the autism unit, again, it worked really well with that individual. There's trust-wide plans to run a workshop, because I think we want to raise the issue about parity of esteem generally across the trust, as well as the broader geography of the area. Yes, thank you. Got it, yeah. And we want to continue to raise awareness of parity of esteem, so there's no health without mental health. So, as a TVN, care, show it. I think that's number one for us, for certainly me and Heather. Acceptance. Although you don't have to show approval for the actions, you can show you understand and that you've got empathy for that individual. Respect for their courage and determination to survive. Bear in mind, lots of self-harmers, their injuries are a medal of survival, not a medal of attempted death. And that's important. And empathy, by listening without judgment, by trying to understand from their perspective, by being there for them and by trusting and supporting them and understanding what they want, really. Lessons learned for us, really. It's okay not to know. These are very complex patients and we struggle sometimes. It's okay to ask for help, push for the collaborative working, be aware of your impact on others and diagnosis and speculation, and be creative and think outside the box. We have to in the setting that we're in. We've got to be able to do that. And be confident even when you're using professional guessing. Everybody looks to us as TVNs as the expert. So if I am guessing based on obviously evidence and experience, then I have to look confident, because if I'm not, everybody else goes into meltdown. So that's important. Know when to back off. So some of these individuals will have to say, right, this is what we're doing, but you need to know when you're going to actually exacerbate the feelings rather than making them better. Share your learning, like today. And still learning, me and the team, every day it's a learning. That's half the fun, isn't it? Being out there every day, what we do. You never know everything, and it's great fun finding out. That's what I think. Right, I've got a couple of quick pictures before Fran drags us off with a hook. So I just wanted to show you this. This is one of the most recent injuries, and this is where social media is having a terrible impact on some of the self-harm. This is a salt ice burn, and this is the current, seems to be the current trend. What happens is the individual wets the skin, puts salt on it, and then rubs ice on the top, and it's a bit like de-icing your driveway. It creates a thermal reaction and it causes a significant burn, and there seems to be a real spate of kids trying to do this, and this has been mirrored within some of our units. So this is one of the examples. These are some of the quick wounds that we've seen. The burns, again, those big round bright ones, that's an aerosol burn, the round one. Again, injuries. This is obviously not this young person, but this is a self-inflicted injury, one of the ones that we see. Interestingly, the patient was playing banjo with a radial artery, but that was something different. This one, the leg ones, they're injection abscesses from frequent self-injurious behavior using injectables, and we see them a lot. And the bicep one, again, parity of esteem, the patient was never offered a bicep repair because he's a mental health patient and he self-harms. So that bicep is actually separated into two halves and bunched up at the top and bunched up at the bottom. So he's lost mobility in the arm and he wasn't offered any kind of surgical intervention because he was a mental health self-harmer. And there's other two books. So thank you very much.